what we do is we obtain a biopsy before treatment begins. Patients are randomized to either receive or not receive the results of a genomic test which was designed to predict the response to chemotherapy. Then for everybody we measure the tumour with ultrasound. We also measure the tumour midway through the treatment at the end of the anthracycline treatment. So this combination of what we predicted might happen at the end of treatment and the interim assessment of response during treatment, during the first half, are combined to make a decision as to whether to continue with the second half of standard treatment, which would be weekly Taxol at our institution, or instead to go onto an experimental treatment arm, which may add an additional treatment to Taxol, or may replace Taxol with a different approach of molecular and or chemotherapies. And so it's essentially adapting to the prediction of outcome and the confirmatory response, and then to select amongst the different types of treatments that might be offered in the second half if somebody weren't responding well or were predicted not to respond well. That is really based on some very general descriptions, molecular descriptions of different types of triple-negative breast cancer. And the whole objective here is to be able to do the clinical trials of new treatments in the patient setting where it's least likely where we're going to get a complete response. In triple-negative breast cancer with standard treatment, nearly half of the individuals who receive that get a complete response, or such an excellent response that the prognosis is the same. And so we really want to focus our drug development and our translational science on overcoming resistance for the other half of the patients. And this is really our best shot forward at this point and our first shot in the Moonshots program.